To this Healthwatch conversation on health and social care services in Stoke and Staffordshire. Unfortunately, the person who was going to chair it, Healthwatch, has had to withdraw on short notice. So they've asked me, my name is Andrew Butters and I'm the Director of Service Development at UHM, to actually chair the event tonight. So what we want to do is we're going to start off, and the chair is John McDonald's going to do a short presentation talking about the issues that we're looking at in that review. Then we'll take a bit of, if there's any feedback from the table conversations that have been going on, we'll take a bit of feedback from the facilitators. And then the floor is open for you to raise issues, questions that you want us to listen to. And we aim to finish by 7:30. Okay, so without further ado, I'll pass over to you.
Thank you very much. Good evening. Thank you for coming. Really just the purpose of the event, I think what we want to do is just share some of the thinking, some of the challenges we face, some of the early ideas about how we move forward, get your views and ideas back as well. Because as we move further forward, thinking about the future of health and social care and care services, we need to involve you and a number of other stakeholders in that discussion, not to come through with...
So I suppose that's okay. Now, not come through with ready-made answers, but there are some really big challenges we face, and I'll come on to those in a little bit. I think what we need to do is fairly clear. We need to look at the quality. We need to make sure we're providing really high-quality services in the right place, where people need them. And at the moment, we've got a system which is fairly centralised, it's fairly bed-based. We're not supporting people as much as we need to go out to the community. And that has an implication not just for money, because if you have large institutions and people are kept in and looked after in ways that is costly, but actually more important, it's not good for people, particularly elderly people. If you come into hospital and you spend more than a couple of days here as an elderly person, you start to lose muscle mass. You start to lose your confidence, and if you spend weeks in hospital unnecessarily when you could be at home and be looked at and cared for, you're going to leave hospital being far less independent than you could have been had you been provided with more time and support outside, and certainly less independent than when you first came in. There's also clear evidence that the longer people stay in hospital when they could be outside and living independently, the higher the mortality rates. So there are some really important changes we need to make for patients. And I'll come on to that in a little bit. But that's the map of what we're talking about. It's a slightly forest boundary because, of course, patients on the edges go to where they're to be treated. So if you're in the east, you'll go and be treated on May, get good care in Derby, or you might go down south towards Birmingham. If you're right in the south, then you may well get your care in Wolverhampton. We also have people outside coming in, so parts of Cheshire, patients who live in Cheshire, it's only about a 15-minute drive from the Royal Stoke. So we have patients from Cheshire coming in. So we are working with the neighbouring SDPs, thinking about the future, but the footprint that we're primarily focusing on is Staffordshire. As I said, we do need to think differently, and we'll talk a little bit about that, particularly in the later presentation. But I just want to emphasize, this is not consultation, it's the first stage of engagement. We will have to have further conversations and further engagement as the plan develops. And this is not a formal consultation. If there are any major changes in services, we will have to go through formal consultation as well. But when we have these sorts of conversations, then the better we're going to have in terms of thinking about the future of health and care. Going to think of the three, and I'll come on to those in a bit more detail and give you some of the facts and figures behind them. But there's no doubt, as a healthcare system, and as a health and social care system, we have been struggling for quite a long time. We have been living beyond our means, we're not meeting the constitutional standards, and I some cases we're not providing the quality of care that we would certainly wish to provide. The other thing is that parts of Staffordshire we have populations which aren't regulated. And Stoke-on-Trent, if you look at the determinants of health as the public health people call them, Stoke-on-Trent, as you well know, has some of the highest measures in terms of determinants of ill health. And we need to think not just about treatment, but also about how we help and support the population in terms of living healthier lives. But just a few things here. You can read those. There's a lot of people who have seen it. It's put out, I think, by the County Council, the story of Staffordshire. And it has one page which is equally appropriate to Stoke-on-Trent. In about 1980, there were just under 5 people in work for every person who was out of work in terms of being over 65 or being in school. By 2030, that figure will go down to just over 2. So we will have half as many people supporting each person in terms of economic support, in terms of care, etc., than we had 50 years ago. And the impact of that and the demands of that on health and social care is really quite staggering. And we're only about halfway through that transition now. So we're now going to need to think very differently about how we support the growing elderly population. As we people know, we know that they have complex needs, they often have comorbidities, they have long-term conditions. And I think that the focus very much should, as we look forward to the next 10 or 20 years, be on how we help people to live well. If you have an extra 1,000 days that you live beyond the average to be expected, but actually you can live out those 1,000 days really well, healthily, independently. And we as a health and care system need to think very carefully about how we do that and how we support people, both to be healthy as a population, but also in terms of the care and support they need. So there does need to be a different focus over the next 15 to 20 years. It doesn't really mean that we treat people. We still have to treat people quickly if they need an operation and take them home and allow them to go home quickly. But we also need to think about how we support people to live well. I don't know if you've realised, we've got the I think most of you've got copies of the presentation anyway. But if you look at many of the challenges in our health and care system, we are towards the bottom. And we've talked about the health determinants. It's the same with cancer mortality. And of course, these things are not unrelated. The health of the population and the quality of the service you get combined to produce some of these figures here. We also have performance our self-organizing system. We really look at how that approach to people to hospital than previously. Whether that's because people need that level of support because they're not as well when they first come in, or whether it's because we, as a system, are supporting people properly out in the community, it's probably a combination of the two. I'm sure it hasn't escaped you notice that our is extremely stretched, particularly with Stoke. The county performs much better and Brighton performs better, but Stoke is extremely stretched, and we're certainly not seeing the 95% of people within 4 hours. Both of the areas are, but we are right at the bottom, with the bottom half dozen trusts in terms of that performance. And the level of people going to their need, the less that's good that is for their recovery. And final access and wait times, once again we see a growth in the length of time people have to wait for their elective operations. That's been seen actually. We won't just fire off that, but the pressures, the enormous pressures are impacting into that. And similarly with cancer. There are very clear standards on cancer. Again, we're not meeting those standards. As I say, what unique in these, one of the things though is that we don't perform well in a number of these areas, whereas some systems just don't perform well in other two. And finally, remember, the health service are really make adjustments for one-offs and temporary relief and all that sort of stuff. We've got a number deficit of 157 million, whereas Stoke about 1.3 billion. So it's quite a significant percentage. And that, if we do that, we can get more efficiency gains. If we not changing the way we're providing care, the next going to grow to 2026, it's about 20% of our spend. So that was a big deficit. We are really good at our needs. With the councils, they're not allowed to overspend, but if we look at what they feel they need to provide in terms of social care, then they also have a huge potential deficit. They have been making adjustments to their services, but actually as we cut into some of those services, and as the domiciliary care market becomes more stretched, then that has implications for our ability to support people out of hospital. And as I've said a number of times, that's local to people. So, we can't really continue like this. We shouldn't continue like this if we think we can provide better care for people. And we can't continue like this because we haven't got the money and we're doing well on our needs. So we need to become more efficient, but we also, as I said, need to change the way in which we provide care. And we'll be hearing from Joe and Steve a little bit about exactly what that model might look like. But we also need to work closely together. We need to look at how we blur boundaries between organisations, how we blur boundaries between resources. If, for instance, some healthcare model can support social care and domiciliary care, and that then fewer people need to go to hospital and be more cost effective, then we need to be thinking about that. And we also have to look at the workforce. There is a real challenge in terms of recruiting the workforce. We know in some places the number of percentage of GPs is 20% of GP posts are vacant. We know we've got a high number of Steve portfolio of portable GPs which are due to retire in the next 5 years. We're not going to recruit the number of GPs we need to because they're not there. So actually we need to think, how can we support GPs in a way which maximises their clinical expertise, but also provides integrated care for patients out of hospital. Similarly, there are some areas within the hospitals where there are difficulties in recruitment. And some of the constraints that increasingly put on our ability to recruit overseas will just make that tighter. So we have to think about how we best support people who work in the healthcare services. And those are the emerging hypotheses. I'm not going to run through all those, but you can read them. There really are a couple of things that have come out. The first is that actually we need a conversation with people about what care they can access, but also how they can self-care, look after themselves. The local government report came out, I think it was last week, wasn't it, which basically said that something like 25% of people who come into our area to see their GP actually could quite easily look after themselves in terms of minor cuts, those sorts of things. That would take huge pressure off a group of people, either GPs or the area department, if people feel that they're able to help and support people to do that. So we need to think about how we do that and the responsibilities that people have for that, as well as how we provide the services. We've identified 5 main themes. We're going to do this. Let's start with the level of care. I know that, we didn't want to stop on that slide. We need to think about how we prevent people from getting ill. Smoking is an area that shows dramatic impact on people with having heart attacks, etc. very, very quickly. But we have high levels of obesity which lead to all sorts of problems downstream. We need to invest in primary community care together with social care and mental health services out of the hospital. We need to look at how we're using our theatres. We're not using it very efficiently for a number of reasons, including emergency pressures, which means lots of people get cancer operations. And we also need to simplify the emergency care system. When you come to our room, even if you're one of those who has to make much longer than expected to, you actually get quite a good offer. You'll see a specialist, you might see another specialist, who probably doesn't diagnostic tests, and you'll necessarily manage outpatient problem very, very quickly. And for 8 out of 10 people, that will be done within 4 hours. We don't have the sorts of offers in a fairly chaotic world. The number of ways to access urgent care across the community, we need to rationalise those and provide people with that sort of offer. So it's more convenient for people to go to places other than just A&E. And finally, we've got to cut costs. So those are the 5 themes, and across all those 5, mental health services, the level press about mental health services, and a very large proportion of people coming to A&E, a very large proportion of people who stay in hospital too long, require some sort of support in that area. And also working with local authority in terms of social care, domiciliary care, etc. There has been obviously much better working recently. There's always been good collaboration actually on the ground, but I think there's much more common planning and thinking around that, and that hopefully will lead to a much more integrated system. And this is where I stop. Thank you.
This is me now. So what we've got to do is develop new models of care, different models of care. We've discussed the fact that the current situation is not viable and it's not going to stand us in good stead in the future as demand increases. So we need to develop the principles that will guide these new models. And the principles are set out on this slide. It's about rights and responsibility. It's about people having a right to good quality, continuous, safe care without gaps between different parts of health and social care, a care that delivers really what people need and what they want. But in exchange for that, there are responsibilities. John's talked about some of this already. It's about people doing what they can for themselves. The first carer for an individual, for a patient, is generally themselves. And clearly the system will step in when they need help, but people have got to do what they can in terms of self-medication, in terms of accessing the appropriate resources, and also in terms of making sure they don't access resources where they don't need to be. We talked about beds, and there has been historically, traditionally, there's been a big focus on hospital beds, and specialist health care always takes place in a bed-based setting, and that's something, again, that we need to stop. We need to stop, 2 reasons we need to stop, because it isn't good for people to lie in bed. We're discovering more and more. Most illnesses don't require bed-based care. Many illnesses are actually made worse by bed-based care, and that's particularly so in the frail and elderly population who we're seeing more and more of. So we need to be able to move away from beds and provide care, be it specialist, be it generalist care, but we need to provide all that care as much as we can in the community wherever possible. What about relationships? Well, it goes along with that. This has got to be a much more sort of continuous, flexible, imaginative approach to healthcare. I always think of the Dutch football team in the 1970s, where the midfielders were in attack, the attackers were in defence, the goalkeeper could be anywhere. And we've got to be a bit like that. We've got to have specialists and generalists, doctors and nurses working together in a joined-up system which has the flexibility to meet patient needs. And actually we've got some help in that, because IT technology enables us actually to make available contact. Whoever needs to be contacted, allows us to make available information about patients. So actually we've got some things going for us, but it needs to be transformed and it needs to be different. So we talked a bit about prevention, we talked about shared responsibilities, and I've begun to talk about care plans as well, which, as I say, we have got wonderful IT potential actually to be able to share appropriately and in a controlled way information about patients, so that whoever needs to know, can know, and that's something which opens up a huge amount of possibilities. You've also got to have trust between different types of health carers, all working together. There can't be barriers that we've had in the past between primary and secondary care, not talking to each other, not sharing information. We can't have barriers between community nurses and general practitioners who've got different files and different information. Those things are very strong.
Hi, my name is Steve Forster. I'm a GP in the city, and what I'm really excited about is about the shift in care to the community. You've been talking about managerial terms, we talk about a left shift, but what we're talking about is trying to get care closer to home. Over the years, everyone thinks about bright shining hospitals and investing in hospitals, and that's fine, but actually patients would rather not be in hospitals. Patients would rather be seen in their own practices, seen in their own community. And the STP will help those conversations go along, but it's something that we would want to do anyway. It is actually safer, it's more efficient, and patients are better. But to do that, we need the investment. Again, investment has generally flowed to the tier 4, the really complex part of the system. We need to be really firm and think about how we get the money to flow and make that upfront investment so that primary care and community services can flourish. And we need to make sure that the services aren't just about GPs and nurses, but about an extended team, such as mental health, therapists, and the whole panoply of professionals who can really make a difference. The other bit is about how these services will work together, and you may have heard expressions like MCPs mentioned. These are these multiple speciality community providers. This is where we get GPs and other clinicians to come together, to work together, to break down those barriers between disciplines, between organisations, so that we can deliver care in a really joined up way. And not just in terms of health, but also in terms of social care. I work in Jubilee, and we have social services on site, and it makes a huge difference. And we should be able to try and roll out that paradigm across the piece, because actually health and social care are part of the same journey for the vast majority of patients, yet we still think about them as different silos. And John has touched on the care record, and I can't emphasise enough, I know Zia's here and others, but an integrated care record will be a game changer in terms of how we deliver quality care at people in their communities, in their homes if they need it, but we'll do it safer and we'll do it quicker. And it's something that we really need to do anyway. And the last thing is just about, the whole thing about this is place-based care. It's about just breaking down all the barriers. So I would hope that we would see organisations coming together, so some consultants coming out to help us to deliver that care in the place that is best suited for patients.
Yeah, me again, this next one. So, what about the quality of care that you see? The first thing, the first most important thing clearly is access, having the right access to care, making care accessible to the patient. And that's a complaint that we have now, isn't it? Very often people wanted care, they felt they needed care, but they couldn't get it. And sometimes those failures in access actually we shoot ourselves in the foot, because as we've said earlier, it results in people accessing the wrong care in the wrong place and contributing to pressures that are already in the system. So we need to keep that simple. We need to make sure that when care is provided, it's in a safe setting. Remember, that's not always a hospital bed. I don't think a hospital bed is a safe setting in many cases. It's a place where people can sometimes decompensate. It's a place where inevitably they can be exposed to illnesses of other patients in adjacent beds, etc. So it's about doing things safely, as I say, but not necessarily in a hospital environment, but very frequently not. If we're going to do this, the workforce is going to be important, because one of the main challenges we have in healthcare, it's not just the money, it's having the right people available to do the jobs we need them to do. And locally we have, several areas where we have difficulty in recruitment. It's well publicised that we certainly like to have more GPs in Stoke-on-Trent and Staffordshire than we have now. And there are many hospital specialties and many areas in care. We talked also about domiciliary care where we've got real shortages of carers. And that's something we've got to address. And we've got to address it by a coordinated plan which makes these roles attractive and gets people trained up in an appropriate way to fulfill these roles. I think certainly that the healthcare element of this needs to be clinically led. It needs to be informed by clinical expertise. So we're doing the right thing for patients. So we need to make sure that the changes that we make are clinically sound and driven by clinical improvement, as well as accepting to make some efficiencies. And in order to reflect that, in order to guarantee that, we need to be performing in accordance with local standards and national standards
that ensure that we can be confident in the quality that we're giving to our patient. And if you go to hospital, as I say, you shouldn't be admitted unless you need to be. Sometimes people are very sick and need to be in beds. I talked earlier about the sort of the total football, and it's not just in the community, it's in hospital, because mental illness and physical illness, the two are intertwined together. When patients are sick physically, that's often aggravated or compromised further, by mental illnesses, and therefore we need to provide not just a physical cure, but a cure for those as well. So we need to work together all aspects of care in the hospital. Shouldn't be expected that when someone's in hospital they're going to completely recover in hospital. They need to be in hospital only so long as they need to be, and there needs to be an acceptance that they will get better, they will make a full recovery at home with the supervision. It's needed to do that if such is required. We'll do more patients as day cases. Clearly that is more efficient. I think it's better for patients. Patients don't want to be sitting in hospital beds if they don't need to be. And we'll also separate, I think this is important, we'll aim to separate as much as is possible planned care from emergency care. And that's because we know that when we do the two together under the same roof, inevitably when the hospital gets busy with emergencies, that disrupts planned care, and that's a real problem because it means people are getting it through a service. It's inconvenient to them, but it's much worse than that because some of these planned procedures are very important. Some of them are life-saving procedures. They involve cancer treatments. They involve other life-threatening conditions. So we mustn't have a constant stop-start of the delivery of planned care depending on how busy the hospital gets. And we must build centres of excellence, and I think we already have some centres of excellence, but we need to continue that and we need to build them further because we have got some fantastic resources in Staffordshire, I believe, both in terms of actually the staff we've got here and the facilities we work in, and we need to make the most of that and make that better. Next slide. So, those are the principles, I suppose, and the key things which are driving developments. I guess things to consider. This isn't a consultation at this stage, but I think that obviously the discussions that we have tonight and on other nights are important, really informing future consultations and actually informing the development of the proposals. So we're interested in views and feedback. And we need to know what can be done better. We need to have people's views of what's the best and the most efficient way to spend money that we've got, the resources we've got, and actually what sort of services are important to people and what services are less important. The other sorts of things we need that there's a constant tension between care closer to home and developing those centres of excellence. Where does the balance sit? How much do people want delivered close to home? How far are they prepared to go to ensure that they're being treated in an organisation that has got the scale, facilities and staff to provide really excellent services? So those are the sorts of things we should be considering.
Okay, thank you, John. What I'd like to do now is we've had some conversations on tables about primary community care, about long-term conditions, about urgent emergency care, and also about information technology and information transfer. And I'd just like to ask the facilitators whether they've got any points from those conversations they want to feed back on. So primary community care, who facilitated that?
Steve? I'm happy to. Thank you. I'll go and stand over there with the rest of them, it's probably easy. Yeah, so a lot of the stuff that was talked about on our table was around really making sure that people have a lot of the stuff that's already been discussed, so getting the right information, getting the right service to the right place, being able actually to get a service that is on your doorstep with your practice, but with a recognition actually that sometimes that might need to be over a larger audience or a larger catchment, say 50 to 70,000 people in terms of what we call a unit of planning. And we were fortunate on our table, we had Councillor Evans with us in terms of linking both the local authorities' needs as well as the population needs from a health perspective. And Dr. Barkle, who leads on this programme for us as well, is around sort of making sure that we recognise that when you're looking at a GP practice, we talk about people in the hospitals that shouldn't need to be there clinically. And actually, when you look at general practice, there's a lot of people actually, if they took control of their health, they had more opportunities in the community and they had more access, then actually they wouldn't need to go to the GP service as well. So when you start to look at that, as the compound effect that starts to build up into the system, that is a really challenging piece for us, because this is now talking about holistic care, particularly from a mental health point of view, physical health point of view, and a social care perspective. So the only thing we talked about around primary care there was trying to make sure that the services are accessible, and we talked a little bit about these MCPs. And the MCP structure, I think it was said more better than I could explain it. It was about providing more services locally in the community than the need to go on a referral basis from one place to the other. And I think that's something that everybody would definitely want, and we would agree with. We might wear suits, but one day we'll be patients, if not we already are. So what we've also got to do is recognise what we would want as well as what you would want, definitely in terms of general practice and primary care. Hopefully colleagues on my table that really gave an account as to where we were at, unless I've missed anything else.
Just think about mobilising what we call community assets.
Yes.
One of the things we've probably neglected in the work we've done already around this is using the community assets that are already there. The meeting points, the supermarkets that people go to, the football grounds that people go to, and how we can use that better to kind of help engage people on the prevention agenda and also the self-care agenda. So I think what we want to do is to work with our local authority colleagues to map that out. I think through our health and wellbeing strategy, that some of us will know that mobilising communities was a key piece of work. And I think we need to do more on that, because I think that's where a lot of the future lies. I'm not going to call it big society, because that when David Cameron did talk about that, but it's off that ilk. What can we do together? We can do much more.
Thank you. The next thing picked up was long-term conditions. Anybody who facilitated that? Any feedback from that? No? Okay, urgent and emergency care?
Okay, so I had urgent and emergency care, but actually we didn't really look at talking about urgent and emergency care at all really. What we talked about was access in general and difficulties in accessing services, particularly for mental health. So we had some discussion around the fact that whether you were in an emergency facility or other facilities, it's still very difficult. So I hope people are pleased to see that that is a very key part of our STP, trying to get that parity of esteem that we always talk about. And I'm pleased to say, because I work at UHM, who I'm actually based at Stoke Hospital.
To look at and to work with you on that, which are around the wider determinants of why people end up using services. So, I would agree with you. It is in there, but it needs to be a bit more prominent. And again, as John says, when the plans get published, these are the kind of the suggestions where there are gaps. This is where we want to hear from everybody to say, you're missing this needs to be added, this needs to have more emphasis.
And as you all know, there are some small schemes, one you're involved in, which meets energy conservation, saves costs, and provides support to people to make their homes warmer. We need to develop more of those, where different organisations, voluntary sector, local authorities, health come together on some of those sorts of things as well. What we tend to see in some of the places where this sort of system has developed, particularly overseas, is that the early stages are very much concentrated on the clinical and the social care aspect, and then the next stage is getting into the wider determinants of housing and everything else. Now, whether that's right or wrong or not, we can debate, but it does definitely need to be built in there. Yeah.
Next question, please.
Thank you, Councillor Jane Bell. Going back to the future of community beds, are we still consulting on the future of community beds? Because we've been told on several occasions by ours but no matter what the result of any consultation is, those community beds will remain closed. So it seems really a meaningless type of consultation if the result has already been decided.
No, we are engaging, we're currently engaging. There are 4 events. The first one kicked off today and this morning, and there are 3 more planned. And then regarding any proposals around community hospitals or community beds, that will be out for full consultation from February next year through to April.
So, just going back, can we have your assurance then that if the consultation is universally in favour of keeping community beds open, the beds will be reopened?
The consultation will happen, we will see what comes back for it, and then we will report through our governing bodies on the back of that consultation. I can't predict the outcome of the consultation, nor can I say what the decision would be on the back of the consultation. We need to hear the consultation first.
That doesn't really answer my question, does it? I'm asking for some assurance.
There is some leaflets over on there which actually give the details of the consultation that's going on, particularly around focused on community services, which has the details of the future meetings. Next question. Ian.
It's basically following on from Jones and Buzz's statement. A fundamental to any form of change is the need to be open and transparent, be accountable, etc. And quite frankly, I accept that community beds aren't necessarily part of the SDP. Quite frankly, at this moment in time, there is an atmosphere, a very poisonous atmosphere of distrust. The community beds that are being shut prior to consultation don't add to that. And I don't know how you are going to regain the trust. This is very important, extremely important. I think a lot of us agree with the direction of travel, but considering there have been premature closures of NHS resources and not facilities open to accommodate the people, I don't know how you're going to now win the trust of the population that actually funds the local NHS, the population that actually helps to fund the local care system, given that there has been a considerable lack, mention was made of collaboration, a considerable lack of collaboration throughout all of these processes, and one can't feel one can trust the SDP process. I've heard that even in the south they're now going to close community hospitals. Could I have your comments on that, please?
Yeah, I don't think they plan to close the community hospitals. There are discussions there about the nature of those, but I think the point about trust is very well made. There's only one way we're going to regain the trust, and that is by putting in place services where people can see that they're properly supported before we start taking out further facilities. And that's the only way we're going to do it. And I think that the secrecy issues which have come up are not helping that trust at all. The comments you made about the plan hasn't been released, etc. So the proof's got to be in the pudding, really, and we've got to demonstrate that we are building. People can see those strengthening community or out of hospital services. They can see how they can get supported better, and we can make some of those changes. The conundrum in all this, of course, is that we are £157 million overspent, and how do we do the two together? And I think we need some honesty in that as well. And if we're shutting things because it's for money, then we need to say we're shutting it because it's for money, and that may have a negative impact. If we're saying we are shutting it because we're going to provide healthcare in a different way, then we need to say that and demonstrate doing it. It's actions, isn't it, not words. We're going to win back the trust. That sounds a little bit trite, I know, but I don't know what other answer there is, to be honest here. I recognise the points you raised. Indeed, I recognise it across the pond only a few days ago, didn't they?
Oh, God. But there is a need for honesty, and jumping the gun doesn't help that.
Any other questions, issues?
Hello, I'm Holly Johnson. I work for North Stafford Users Group, which is a mental health group. I work quite closely with them. It's just to say, I've been around a long time. I've been through the Better and Future and all those other programmes and about the community services and that before. And had we done this 5-6 years ago, I think we'd have been in a better place. So I think a lot of time has been wasted. The walk-in centres were a good idea, but they've been allowed to go their own way in our GP practices, which hasn't helped, and they're quite expensive. We're not going to be able to recruit GPs, and a lot of GPs retiring. So I think we need to look at making more use of nurse practitioners, nurse prescribers. I've just been for my yearly check-up with the nurse, you know, what's things like that. I think the walk-in centre were a really good idea, had it worked how they were originally set up. And that was helping, I think, to relieve some pressure on the hospital. But as time's gone by, that's gone by the wayside. And I think, like Ian says, a lot of people are thinking, well, what's the use? You've already made up your mind what you're going to do. Why are you consulting with us? But we as an organisation just gone, they'll keep banging heads against the brick wall, so some regulators do anyway. But, you know, you really need to get this right this time because we're not going to have more chances. And we've got to be as honest as possible with it. And my role is to make sure surgeons are involved. And I did speak to Penny after the Healthwatch Stoke AGM before she had to go and said how much user involvement you've had so far in this process, which you haven't. And I know it might have not been easier, but you must make sure that as soon as possible get patients and surgeons involved in this process at the earliest possible chance. Thank you.
Okay, I'll take some clinical bits. I think you're absolutely right about the problem about obtaining GPs. And I think the bit about using extended teams is exactly the route we need to travel. So within my practice, I've got 3.5 AMPs now. I've also now got a prescribing pharmacist working in the practice. There's another practice I know I've got using paramedic officers to do some of their on the day stuff. We're also looking more about how pharmacists generally can be tied into the primary care offer. And it is the way of the future. This MDT, sort of a multidisciplinary team is going to be it. I think the other thing about walk-in centres per se, I mean, they're complex issues, and it was part of the Darcy programme many years ago. But I think we're exploring other new and actually interesting methods. So we've opened up a new something called a primary care access hub, which is opened up in the south of the city, and where historically they've had poor access to those sort of urgent care type facilities. We're getting more ideas about how we can develop more primary care access hubs like that across the piece. So I think it's about a question of watch this space, because I think they will develop a pace as part of the STP and as part of a general development of primary care.
Just want to add to that, and then perhaps to Ian's comments, is, I'm saddened if we have lost trust. I think, trust is critical between the commissioners and the general public. It is our job to rebuild that trust. Part of the engagement that we're undertaking over the next 4 weeks is, faced with the situation we're facing, what should we do? What would you suggest we do? What are we missing? So that's a key point to that engagement. Then during the consultation, it will be absolutely to the same, right, following on from that, we've got a few options. Now, what can we all do together and go out and hear what you've got to say? So I would hope that you're not hitting your head against a brick wall, that you will be a very strong voice in both the engagement and the potential consultation going forward next year.
And you're absolutely right on patients. So last night we were at a session down just north of Wolverhampton. There was a lady there with degenerative disease, and she often needs physio support. She can get it quicker, and we'll get 10 sessions if she goes to A&E, than if she'll only get 3 sessions if she goes into the GP, because of the way the system works. That's crackers, absolutely crackers. So what does she do? She goes to A&E, because that's a sensible thing for her to do. Next question, please.
Sorry to labour this point. You said that you are not allowed to publish the SDGs. There's a perception out there that's been created that the publication is down to the local leadership to do. So who's actually blocking it?
We are allowed to publish them once they've been through the review process at a national level. So some SDPs have published because they've been through the process. There are a few who published, or where councils have published the SDPs. but we submitted them, there's then a review process, and then they come back, and at that stage we're allowed to publish them. So it's not that we're not allowed to publish them, but we have to go through a review process before we're allowed to publish them. So that's what's happening. And obviously that's going through as a sort of phased process.
Can I just make a point, John?
Yeah.
So although we haven't been able to officially publish, what we have done is produce this discussion document, which draws on many of the issues that are covered within the STP. So although it's not there yet, it will begin to kind of surface a lot of things that will be in the STP. So we have sort of come to a compromise so that we would have something to discuss at these events. Because we had hoped originally we would be able to bring the whole STP to these events. But this document, which many of you may not have seen yet, which is over on that table, actually begins to air a lot of those issues. And that has been shared with the councils as well.
What's your timeline for publication? When do you expect to be?
That's determination. But I would really have it by the time we have the second of these sessions in Stoke, we will have published.
The national debate, if you can take part.
No,
a lot of people ask me questions about SDGs across the country, and here we are in Staffordshire, we don't even know what's in there.
And
that's in the interest of everybody. I mean, look at the recent scrutiny meeting, the council conceded that they weren't even part of the development.
Well,
considering that part of this is open services, that's a problem.
well, the council have been to a number of events, and James has been to a number of the workshops, etc., and Les was out and others have. They haven't gone through a formal process yet, that's absolutely right, and we will want to do that in terms of getting more formal feedback from both the councils and indeed the NHS boards, etc. As I say, the Simon Stevens has given a commitment that every SDP will be published by about the middle of December. I'm pushing and we're hoping that actually will be much earlier than that, because my view is that the sooner we publish, the sooner we can remove this sort of vacuum, and people can then say, actually, that looks rubbish, or that looks good, or what do you mean by this? And, you know, we are pushing to do that as soon as we can. I'll be very disappointed if we can't, sometime in the next 2 weeks or so, but it's not in our gift. It depends on the process of review, actually. Okay.
Next question, please.
Hello, it's Jane Evans from Stoke CCG. Just looking at the problem from another way around, just made to learn some of the answers with the reflection rate. We've got a £57 million deficit. So, just focusing on that for 1 minute, what lessons have been learned? What depth have you looked into the reason for the deficits? What lessons can be learned? Have you got a brief breakdown, a rough breakdown, and are these areas going to be the key areas where you just target and cut?
Yeah, we have done quite a lot of work looking at the underlying causes, and part of the account tonight, the fact that we're treating people in expensive facilities, the fact that we're keeping people in facilities for long enough, the fact that we've got, for instance, theatres across the whole of Staffordshire which aren't always being used as efficiently as they have been. And so we know what's driving the costs, and in sort of very simple terms, closing that gap depends on two things. First of all, is continuing to live about a 2% efficiency gain a year, and that's around things like how well we procure our goods and services, all those sorts of things. That's quite a lot lower than we've done over the last 2 years, because it's not sustainable to carry on delivering 4 or 5% a year. The rest of that will come out of, some of it will come out of transforming care, and some of it will come out of more major facilities. I think we need to be absolutely honest that if transforming care closes 20% of that gap, then it would have done very well. Yes. Let's not pretend that transforming care, which requires investment in other systems, is a panacea to all of those. We've got a program, I think our STP doesn't quite balance in 5 years' time. We're about £40 million adrift. We're having discussions about what that might mean when you look at other options. But both the scale of the financial problem here and the success in closing it is very common. It's the same in a number of other STPs. The other bit that we still have further work to do is how we work with the local authorities in terms of some of the social care services and the support of those. Because if we don't have social and other care support, then there will still be people in hospital who shouldn't be there, even if we've got all the clinical support they need. So there is areas of further work. As I said, it's not a fully funded plan. It doesn't quite balance yet. There's further work to be done on that. And there's one or two areas where it needs some more work. But about half of it is the efficiency gain. I think I'm looking at Steve, that's right, isn't it, Steve? And about half of it is about 10 other initiatives which have varying degrees of savings on.
Any other questions, issues?
I'm sorry about that. Right, 2 points. 2 points. What regard will be taken the effect of surrounding SDPs and impacting on your SDP? Because the Leeds Northwestern one has got A&E and Maxfield shutting. And the other point is there's been considerable concern amongst us. We know the North Staffordshire health economy, the care economy, etc., etc. And I understand about MCPs and the 80,000, 60,000 footprint I believe they're planning out in the Black Country at this moment in time. But how are we going to, I mean, health, illness, there's a socio-economic link, is there not? How are you going to maintain, we are a deprived area in Stoke-on-Trent, how are you going to maintain the integrity of services here? Okay, they've got to reform, etc., etc., that take into consideration what is, in effect, a North Staffordshire footprint. We are very different to the rural south. Very, very different. How's that going to be maintained?
Well, I think in a lot of ways. The first one is that there clearly has to be very close alignment with the local authorities. Yep. If you look at the commission spend, etc., there needs to be absolute transparency on that.
Right.
Secondly, I think we're going to have 23, subject to further detailed discussion with people, roughly 23 of these integrated local care teams. That's where the local focus needs to come.
Yeah.
The debate which is around that is what's the architecture to support that? And that we need to do further thinking, we need to engage more widely with different organisations, etc. But we do think that there's going to have to be a rationalisation in the number of CCGs, because clinical commission groups need to be moving, and the commission needs to be moved more strategic and aligning itself much more closely with the thinking around things like housing and those sorts of things as we talked about. And we do think there needs to be some rationalisation in the provider organisations, because we're going to have more organisations. There are a number of options, they're spelled out in the document, but we have to do further discussion, further analysis. And it's also a question of timing of those, because we need to make sure we can develop those local teams. But we also have to reduce management and overhead costs as well. So the answer is that there is going to be some rationalisation. There has to be. There's widespread agreement on that. The precise detail of that will be worked out over the next 3 or 4 months, and we'll have to go out and then work out what that is. But we're already seeing different organisations coming together. For instance, Stoke and North Staffs have a single, or moving very closely to a single management team. We've got 3 CCGs in the south, the same sort of thing. In terms of out of areas, there are 3 key areas we need to think about. The first is Derby Burton. They're not infected with people here. It makes absolute sense that those two should work much more collaboratively. Whether that becomes a merger or collaboration is still to be thought through. The second is Wolverhampton in the south. Because lots of patients go to Wolverhampton or Walsall or wherever else, and we're not looking to change those flows, but we need to be clear about how that relates to some of the community provision, GP, provider, social care provision. And the third area is Cheshire. And it's not just Macclesfield, it's also Leighton. I mean, Cheshire have 4 small hospitals, over an hour between each of them. And, we actually have been working very closely with UHM with Leighton. So I've already written to those SDP chairs and said we need to have some further discussion about what precisely this means. We need to understand the implications of what they're thinking about, vice versa. But we have been having discussions along the way with them. Okay.
Okay.
Anything else that people want to raise this evening? Steve.
Thank you. If I can, thank you, sorry, Jane. I I think one of the things that's really important to you about the point that you just raised is Staffordshire's a big place, and North Staffordshire is equally a big place. And so one of the things that the clusters are trying to do is to localise health around those areas. Stoke is different to Tamworth, different to Hanley, different to everywhere else. So instead of just saying that we've got footprints that are socio-economic, that are of scale like this, when we break it down into these footprints of 70,000 populations, it's much easier to manage. It's much easier then to tailor and focus what the needs of that local populace are, because you know, I've lived in Stoke all my life. Stoke needs are very different to another county's needs and very different to another town's needs. So we have to do that. The other thing that's really important is to join them together to make sure that we learn the lessons, but we use the resources in a way that we can manage that better. And that will also help. You know that some general practices are really struggling in terms of with their consistency of delivery, their quality of the care, actually having the right workforce in place. So the best thing that you'll see from this particular transformation program is a grouping together of those practices to help them sustain. Because we are not going to just grow GPs on trees, they're not going to emerge out of the system. So we've got to do something now. And what John is talking about, the system architecture, is a lot more complicated and a lot further down the line actually, because we've got an issue that we need to deal with right now. And so you'll see these clusterings start to happen immediately. Once you start to see that, we'll start to see some of the pudding stuff that John talked about to really get into grips with real local operational service delivery. I just hope that was helpful. Just Thank you.
Any last thoughts, no issues? Okay, there's information about this process, future events, and tonight on a booklet or a leaflet in the pack you've got. I'd just like to say thanks very much to our panel members and to you for your attendance and participation. Thanks very much. Thank you.